All right, Dr. Fanari will continue here with a case of transcatheter management of saphenous vein graft aneurysm using Viabond covered stent.
Thank you very much again for having me here. I want to thank my co-operator on this procedure. So basically, the reason why I'm presenting this to explore one of the transcatheter management options for saphenous vein graft aneurysm and fistula, actually. In this case, it was also, there was a fistula, as you will see in a minute. So this lady, 66-year-old lady who had CABG in 1996. So she actually had CABG when she was 42-year-old. And she had edema to LAD, and she had venous vein graft to the RCA. She presented to our ER actually with non-STEMI and severe heart failure symptoms as well. Physical exam, she had actually very interesting to and fro murmur in the mid-sternum. So when we did the cardiac cath, we did not find any lesions. The only thing we could see actually is this. So basically, this is the right, this is a saphenous venous graft to the RCA. And we had actually, you can see here, there's a vein graft aneurysm. Not only that, you can see actually the vein graft, there's a flow going all the way to the right atrium. And what you see here, actually, we had, this is Swan catheter, yes, thank you. So again, this is Swan catheter in the, actually we kept it in the right atrium. So you can see actually, like, the reason why we have it here is just to confirm that this flow is going to the right atrium. And we also did some measurements. We'll talk about it in a second here. So CT scan actually showed this is the size of aneurysm. You can see actually it's almost 3 centimeter by 2.7 centimeter. It's very big aneurysm. Part of it is thrombosed, as you can tell, but they still have a lumen in it. And here in the next slide, you can even in the CAT scan, you can see, look at the contrast concentration. You can see the contrast going from the aneurysm to the right atrium right there. So basically, we tried to manage. So at that point, when we did that procedure, the diagnostic procedure, obviously we decided to stop and think about our options. We tried to treat medically for the heart failure and chest pain. Unfortunately, nothing really helped with that. When we did the right heart cath in the procedure, so actually the RA saturation was 85%, which is very high, which tells you how there was significant shunting of blood from the right atrium through the fistula. And actually QBQS was 2.1 actually in this case, which is actually very impressive for just an aneurysm going to the right atrium. So basically, this shifting actually was causing, I think, volume overload on the right ventricle, and that explained the heart failure in this case. The left ventricle function was actually normal. We actually consulted our surgical colleagues, and they felt the surgery was actually, we did the CAT scans, they felt the surgery actually was not an option. The reason is the lima actually was going very, the lima actually was going very close to the sternum. So if they have to open the sternum again for repeat sternotomy, they were going to severe the lima, and then this patient will not have flow. This aneurysm is limiting the flow to the right coronary artery, and she will not have flow to the LAD, and that will actually put her at very high risk. So we decided to manage this medically, and with percutaneous interventions. The problem here, it's not only heart failure, so we close the aneurysm or fistula. There's also significant chest pain, very typical chest pain, because of the ischemia on the right coronary side. So we had also to find a way to keep the flow going to the right coronary territory without getting any flow to go to the right atrium. So the only option we have there actually to have a stent, covered stent usage. So the aneurysm, as you could notice earlier, it's really big to use the coronary covered stent. So we actually felt that the only option we could use here was Viaband covered stents. So basically, we did IVUS imaging and did measurements, and just to confirm which size, and we decided, I think, to use 5.0 Viaband stents. So when we did the IVUS, we did it on 014 wire. We exchanged this using a quick cross for 018 wire to put the Viaband on. However, it's kind of like very interesting. After we did this case, actually, I got two other cases. I tried to go with a Viaband on 014 wire, and actually it went easily if it's in the right coronary artery. You have to use 8 French. You have to use 8 French guide when you are doing this, and we used 8 French multi-purpose guide. So Viaband usually will go with 6 French sheets, but when you go convert that to a guide, that goes to 8 French guide size. So here you can see the guide up there. You can see the wire. You can see the aneurysm there. We got that. We deployed actually the first covered stent. However, unfortunately, we still had some flow. We both dilated this very aggressively. We still had some flow. So we ended up doing another stent, putting another stent inside the first stent, and both dilating both. And we got actually great results. So here you can see the flow. So this is still RCA. You can see there's a good flow now. Earlier, you could not see that. And there's no flow in the right side. Actually, what's interesting, the SATs went down from 85 to 65 within 10 minutes. And the pressure, pulmonary artery pressure went 10 millimeter, systolic pulmonary artery pressure went 10 millimeter down from before the intervention, which was very significant as well. So you can see here, we got very good results at the end. This is the CAT scan later on. You can see actually the more thrombosis inside it. Very good flow. This is the venous graft lumen, which is very good. You can see even the size is 2 centimeter by 2 compared to almost a 3 by 3. So actually it shrinked as well. The patient did well after all, no heart failure symptoms. So the take message from this case is you actually may see these pseudoaneurysms. And most of the time, they don't cause fistulas. And you can either coil them or close them with plug, depending on the area that's provided by this aneurysm. But in some cases, it may cause fistula, and you may need to achieve 2 things, which is achieve good blood flow, maintain good blood flow distal to that aneurysm, while you are excluding the aneurysm to let the aneurysm thrombose. And we were able to do that with the Viaband. So in the past, most of these cases were managed medically and surgically. Now we have many options for percutaneous interventions, as I said. Thank you very much. I want to thank my co-operator, Dr. Weiss, as well.
Great, that is a great case. A couple of questions. Yes. So when deciding the mechanism of this, or thinking about the mechanism of this, what do you think this came from? What's the origin or the pathogenesis here?
Right, so this is probably a pseudoaneurysm. So it's not really clear what's the pathogenesis of this. Some people say it's actually comes from initial injury with scalpel when they are doing the surgery. So it's kind of like a surgical instrument injury that actually get exaggerated response and cause pseudoaneurysm. But it is not really well understood what's caused them, actually.
Yeah, that makes most sense, really, that this is a harvest injury and it's a time of surgical implantation that then progresses from then on out. The next question is, there's a balance here, right? For sure, exclusion of aneurysms, pseudoaneurysms is one very established way of treating these situations. There is a counterpoint to that, and that is restenotic and thrombotic risks, especially when implanting a big platform that's not meant for the coronary. Was there any consideration for plugging the fistula from the RA side and trying to keep any device out of the vein graft entirely?
Yes. The only issue that we were worried that if we embolize something while we are plugging it from the right atrium, this may go through the RV and go outside of that, and we didn't want that really. So that actually was a consideration for us, and that would make actually more sense. But the location in the right atrium is very difficult to get in first, and then it's actually big fistula, so we were worried that whatever we were going to embolize there may actually not stay there and go through the fistula to the right atrium, then through the right atrium to the right ventricle. That was a big risk. The thrombosis is a huge risk, obviously. Stenosis is a risk, I mean, especially here we put 2 stents, but the lumen is big, like we're talking about 5.0 lumen, and we went up with, like post-dilation, we used the very high pressures with 5.0 balloons. The main issue with covered stent is stent thrombosis. They have a huge stent thrombosis risk. Yeah. This patient, it has been, I think, like now more than 18 months, and she's still on dual antiplatelets because of that stent thrombosis risk. Right. And obviously that increases the risk of bleeding, but as we said, we have to balance the benefit and the risk, and that's what we can do.
100%. Yeah, one of the interesting techniques I think that would have been good to try would have been to wire the vein graft wire down the fistula into the right atrium, and then snare from there. And then take a delivery sheath retrograde up the fistula and deliver your plug from the RA side. That way you get some sort of disc device. AVP2, ADO2s would have been nice in this scenario. You can even consider doing AVP4s and leaving the entire well-sized plug in the fistula itself and getting away from the vein graft. Something to consider.
These actually are great suggestions.
Yeah. Yes. Thank you so much. That was a great case.
Thank you very much. Thank you.
All right, signing off from CVI 2017.